Thanks very much, Magnus. I think the more I move along, the more I realize how much I don't know. So if somebody tells me they do know, I say, well, where's your data? And therein lies one of the biggest problems we have. And that's where our data is and on what we base things. My task was to give a talk entitled to Improve Growth in Preterm, particularly the very low birth weight infants. Well, I can summarize it now and then finish, and you can give me your questions. And my first point, serious point, is each NICU should audit outcome before and after hospital discharge, and in the process assess feeding practices in terms of scientific basis and consistency in application. I've almost got to the stage where when we get into discussions, if you don't have outcome data, there's little room for discussion. There's no point in telling me this is what happens in our unit if you don't have the outcome data. The second thing is I think we have to have a better understanding on the effects of illness and the interventions on the infant's nutrition status, whether it be diuretics, steroids, etc. We really must have a better feel on that. And we must also understand better study design, therefore the interpretation of interventions designed to improve growth before and after discharge. I'll develop this a bit later. Now, despite recent advances in nutritional care, including early aggressive parenteral nutrition, minimal enteral nutrition, fortification of human milk, postnatal growth failure remains an important problem in preterm infants. And these are the results of a recent multi-center trial. And on the upper column, you have weight Z-score at birth and length Z-score. Between birth and entry in the study, all of these infants develop postnatal growth failure. And by the time of discharge, on average, it had not improved in either group. So postnatal growth failure remains an issue even in institutions who have major nutritional interests. Now, is it important? Well, I'd like to step back a small bit and just re-emphasize some things. Yes, we have a paradigm: malnutrition, altered cell function, structure and function, altered organ function. Now, in adults, there's a huge amount of data there relating malnutrition to alterations immune, pulmonary, GI, and so on and so forth, right down to the development of cancer. In children, it's been directly related to reduction in lean mass, muscle weakness, altered neurodevelopment, altered immune function, and increased incidence of infection and increased wound healing. Now, we really need, there are a lot of studies out there looking at the relationship between growth and neurodevelopmental outcome. This is one more recent study done by Sandy Dharmaraj when I was in Newcastle. And the original hypothesis of the study was the greater the growth failure between birth and 28 days, the poorer your neurodevelopmental outcome. If you follow that, and babies were stratified into two groups, those with mild growth failure between birth and 28 days, and that meant a change in Z-score of less than 1 standard deviation, and severe growth failure. Have we got a pointer? I'm not sure how I'm... Oh, yeah. Anyway, it's a bit difficult without the pointer, but what I want you to look at is at 28 days, babies were stratified into two groups, mild and severe. Then they were re-stratified, they were prospectively followed and then re-stratified at 18 months. And we got 4 groups. Those who were mildly growth retarded throughout, those who were mildly growth retarded and fell off, those who were severely growth retarded and fell back, and those who were severely growth retarded and recovered. And what we saw was that those who were mildly growth retarded throughout had much better neurodevelopmental outcome than those who were severely growth retarded throughout. But what we also saw was that those who had early severe growth failure and recovered had much better outcome than the other two groups. What this means is that, and we're looking at recovery that occurs after discharge, which underlines a very fundamental important point. And that is it's not adequate to give results just between birth and discharge alone. Follow-up after discharge is critical in our high-risk infants. Now, the interrelationship between malnutrition and illness is complex. Deficits are multiple than single. The effects may be well downstream, and the effects are always confounded by other factors, such as concomitant illness and its treatment, socioeconomic factors which may have a significant effect in cognition. And at the same time, when you try and study it in vitro, animal and human responses are different. But there still is a direct, almost vicious circle of malnutrition, altered organ function, development of disease, and altered nutrient metabolism. The ravages of malnutrition are much greater during infancy, and particularly in very low birth weight infants. Why? Well, illness and injury are much more common. Inflammation is much more common. The rate of growth of a very low birth weight infant, babies double their birth weight between their program between 24 and 30 weeks. They triple it between 24 and 34 weeks, and they quadruple it between 24 and 38 weeks. At no other time in life is it that fast. Requirements or needs are a function of the rate of growth. The greater your program growth rate, the greater your need, the more likely even marginal effects, marginal deficiencies are going to have a significant effect. At the same time, metabolic mass is increased. If we look at the brain, what we see is very much increased in the preemie, not so much different, but very much than the adult. You see a significant metabolic mass for the lungs. The lungs are still supposed to be growing at a very rapid rate and therefore very vulnerable. Thus, particularly, half of the reasons we get such bad BPD. And then when you look at the liver, you think of the potential long-term effects in metabolic disease, and particularly dyslipidemia and insulin resistance. Now, additional considerations in the immature baby are the effects of immaturity. Intake is reduced, absorption is reduced and altered. At the same time, and utilization may also be affected. Needs are not well defined, and measures of outcome are disputed. If you asked Magnus, and you asked Jean-Charles and myself, and you said, tell me, at what rate do you think a baby should grow at? I don't think you get the same answer from any of us. We're still uncertain what is the appropriate rate of growth we should be receiving in a preemie. Never mind what the composition nature of it should be. So we're shooting at this thing in the air that's there, but we're not sure quite where we're trying to get there. The net effect in preemies is intake is less than need. They develop a significant energy deficit, and they develop a significant protein deficit that may or may not, that can be directly related to the fall off in growth. And as Magnus has taught and people have asked, they also may develop mineral deficits, one of which obviously is phosphorus. Now, in preterm infants, needs are determined using the Factorial Approach. And in using this approach, needs are related to needs for maintenance and needs for normal growth. Now think about that. What happens in the preemie is a sick preemie doesn't grow. So the minimum requirement that baby should get in the first 2 to 3 days if they're sick or they're developing is enough energy to prevent catabolism, enough protein to balance ongoing losses. That's what you have to think about, is intake meeting needs, but needs are changing. In the non-sick infant, using the factorial approach, Eckert-Zierler looked at the intrauterine composition. And what you see is, as with advancing gestation, the amount of protein accreted decreases from, where we're getting, 3.5 down to 3.2 grams per kilo, while fat accretion increases. And the relative protein energy need for the infant decreases from 3.9 down to 2.9, with an average requirement of about 3.6 grams per 100 Kila Cals. Now, in this respect, this is very interesting. We recently completed the same multi-center trial wherein infants received 3.6 or 3 grams per kilo. And what you see is birth and entry, Z-score decreases. It's maintained in the infants receiving 3.6, and it's falling off in those receiving 3 grams per 100 Kila Cals. If you now go and look at change in length Z-score, you get the same patterns. An intake of 3.6 grams per 100 Kila Cals barely meets minimum energy and protein needs in the otherwise normal preemie. Now, what you've got to remember is that these infants don't always have a clean passage, and you have episodes of illness where they fall off the growth curve even further, and then you get them up and you get them going again, but they're falling progressively away from where they should be. Now, what's the way forward? Well, every neonatologist knows how to feed a baby, and everybody does it with widely differing results, even in institutions with a major expertise. There is therefore a critical need to audit outcome in each unit. If you don't remember anything else I've said, this is the most important take-home message. How well are we doing it? And the simplest way to do that is to look at Z-scores. And change in Z-score between, change in Z-score between birth, in this case it was the entry in the study, and discharge. Simplest, easiest way, birth and discharge, and then you see, do we have a problem? If you don't have a problem, then there's nothing you need to do. You're doing fine. But if you do have a problem, and most, then I think you need to go to an audit. And I see audit just simply as a continuing process in between units where outcomes of interest are identified and evaluated. And in this situation, we're looking at growth. And I think the simplest way to do it is, Magnus has showed you, look at Z-scores for weight and length. And then you go and you must do it before and after discharge. We have to see what happens to these babies after they go home in a critical recovery period somewhere between discharge and 2 to 3 months corrected age. We can't let them go and let somebody else take care of them. We got to remain have a much more active interest, much better follow-up of these infants, and make sure that they're getting back to closer where they might have been. Now, if a problem is identified, then I think you've got to look at achieved energy and protein intakes. You look at your TPN practices, your enteronutritional practices, but you also start looking at illness and how you're treating it. Babies who receive diuretics fail to thrive. Babies who receive steroids fall off the growth curve. Babies who receive xanthines have a higher energy expenditure. They do not grow as well. There's some very nice studies done, it's a while back now, where they looked at apnea of prematurity. And they randomized looked at energy expenditure in infants who were receiving CPAP for apnea of prematurity and xanthines. Those receiving CPAP grew much better. We've got to be, if we're going to improve outcome, we've got to be a lot more critical of what we're doing when the baby is ill and how we're treating them and how long we continue it. Now, assuming that inconsistencies are identified, then I think there needs to be an evidence-based change as institute and practice standardized. There have been a huge number of papers today and previously looking at this. I was interested in the meta-analysis by Patoli where they looked at the relationship between standardization of practices, and all the practices were different, and the incidence of neck. And what they showed is it didn't matter what you did. As long as it was consistently done in the unit, the incidence of neck fell. Wow. Imagine the neonatologist getting around, agreeing to disagree, and move ahead. Wouldn't it be marvelous on a consistent basis? What did I learn from Audit? What we thought was happening and what was happening were not the same thing. How about day-to-day practice on the unit? A question could be asked, how often should an infant be weighed? Can I have a hand count? And just put up your hands and I won't look at your face. How many of you weigh babies daily? Every day? Okay, good. A lot of people weigh. I can't give you a good reason for weighing a baby daily over the first 2 to 3 days. Weight gain was never programmed to occur in a linear fashion. Weight gain is programmed to occur in a saltatory fashion. It's in growth spurts. And even here we're looking at this is a normalized growth curve. Here's the way it's actually occurring in practice when you look at weight gain in grams per day, or grams per day. And there's a whole huge body of literature there saying exactly the same thing. So to me, it makes little time. I would like to leave a baby alone, put them in a cocoon, feed them what they need, leave them, and let them grow. The less intervention we do in them, the better off it is, unless you have another consideration. And that is inappropriate weight gain because you're worried about fluid and electrolyte balance. That's the only time I can see any difference. Then the next thing is, should actual weight be used as a reference prescription for intake? How many people, hands up, say it should? How many of you use the daily weight as a reference point to determine how much to feed the baby? Don't be afraid, I want to just get an idea. Okay, most of you do. An intake that's related to a suboptimal weight means you underfeed the baby. Duh. Okay, now let's move along. Should weight be used as a reference point for growth? Well, I've shown these almost too many times. If you take a preterm infant, 26-week, 750 grammer, who loses weight for the first week, regains at the end, and grows at a rate that parallels that in utero, which is what is currently recommended, this baby will only weigh 700 to 800 grams less than they would have been if they were in utero. If you take a smaller baby at 500 grammer at 24 weeks and does the same thing, this baby will weigh 1,300 grams less than where they should have been. If you compare an AGA and SGA baby at 26 weeks gestation, there's a 500 gram difference. Intakes and accepted growth rates that relate to the measured body weight systematically means you systematically underfeed, and therefore babies will never achieve their growth potential. Next question, how should it be plotted? Well, I like Z-scores, and I can get an idea of nutrition status of birth in a group. I can see how it's trending over time and get a better sense of how vulnerable the baby is. If I'm looking at an individual infant, I find this is very useful. I think that tells you immediately, much better pictorially and easier to present to the nurses when you're talking about feeding babies. Now, lastly, in the way forward, I'd really like to talk a bit about study design. Study design in preterm infants is modeled on that in term infants, yet there are many differences between the two. One of the biggest ones is that you've increased in background variability or noise in patient characteristics is much greater in preemies. And my thought is that there's a greater chance of accepting the null hypothesis because of large background noise than rejecting it when examining the effects of an intervention on growth. And this stems from two recent set of observations. We originally did a balance study that lasted a short period of time, and we're looking at the effects of nutrient balance, the effects of two different levels of protein, 3 and 3.6 again on nutrient balance, and we looked at weight gain. And what we showed was a significantly big difference for girls and boys. We then went out to try and do a study, which I've just presented, on a much larger scale. And the magnitude of effect was incredibly different, much, much less. It was there, but nowhere as great. So I started wondering about this and thinking what was going on. Well, babies were stratified the way we'd normally do it, less than 1,000 grams. These babies were all less than 32 weeks, stratified according to gestational age and greater or less than 1,000 grams. And so now we have a situation where we provide variability in fetal experience, fetal growth. We have a large variability prior for normal health and development. Better nutrition, less illness, and better health Better nutrition is the a prime entry point to end poverty and a milestone to achieving greater quality of life. Well, I've translated that into the preemie. Well-nourished preemies sustain less illness, recover quicker, and go home faster. Long and short of it. Better nutrition is the prime entry point, limiting the effects of immaturity, illness, and iatrogenic disease on organ growth and function, therefore development and ultimate productivity. Our imperative is to do that better. And we start off by auditing what we do. The second thing is we understand why we do what we do and are much more critical about it. Thank you very much.